Okay, so over 30 million people in the U.S. are living with diabetes. That number alone is pretty staggering.
It really is.
But here's what gets me. About 1 in 4, maybe even more, they don't even know they have it.
That's the truly surprising part, the unawareness.
And it gets bigger. Over 84 million Americans have prediabetes. And again, like 90%, totally unaware.
Yeah, the scale is just immense. Millions walking around either with it or on the verge and just not knowing. That lack of awareness is a huge barrier.
Definitely. And look, if you find wading through all the complex health info out there a bit overwhelming, you are absolutely not alone.
It can be a lot for sure.
So think of this as your shortcut. We've done the digging in this deep dive into diabetes essentials. It's going to give you the crucial information you really need.
We're using a great resource too, right?
Exactly. We've got a quick study health guide on diabetes care, management, and prevention. And we're basically pulling out the most important bits.
It's like the history, the different kinds, how you spot it.
How it's managed, and really importantly, what you can maybe do to prevent it.
Yeah.
Our goal today, simple. Make this clear, make it engaging, and make it genuinely useful for you. So let's start right at the beginning. What is diabetes, fundamentally?
Okay. So at its heart, diabetes isn't just one thing. It's really a group of conditions, and they all affect how your body uses glucose, blood sugar.
Right.
The basic issue is either your body doesn't make enough insulin, that's a key hormone,
Mm-hmm.
or the body's cells just don't respond properly to the insulin that is there. Either way, you end up with too much sugar floating around in your blood.
Okay, so sugar comes from food, obviously, but I remember reading our liver plays a role too. Can you, walk us through the normal process first
Yeah.
before we get into what goes wrong?
Sure, yeah. Normally, when you eat food with carbohydrates or when your liver releases glucose, it's stored.
Sure.
That sugar goes into your bloodstream, blood sugar levels go up. That signals your pancreas. It's a gland sort of tucked behind your stomach to release insulin.
And insulin is the key, you said.
Think of it exactly like a key. It unlocks the doors on your body's cells. That lets the sugar move out of the blood and into the cells.
Where it's used for energy.
Exactly. Fuel for everything you do.
So insulin is the delivery guy getting the fuel where it needs to go.
Yeah.
But with diabetes, that whole system is messed up somehow.
Precisely. The delivery isn't working right.
And the consequences, having all that extra sugar just hanging around in your blood, that can cause real problems down the road, can't it?
Absolutely. Over time, if your blood sugar stays high, it can really damage organs and systems all through your body.
Like what kind of damage?
Well, it significantly bumps up the risk for serious things like heart disease, kidney disease, even losing your vision. That's why getting those blood sugar levels into a healthy range and keeping them there is so vital.
Okay, got it. So that's the basics of what it is. Now, you mentioned history earlier. This isn't some new thing humanity's dealing with, is it?
Oh, not at all. It goes way back. Our sources say that descriptions matching diabetes symptoms, they show up in early medical writings from as far back as 1500 BCE.
Wow, 1500 BCE.
Yeah, but the name itself, diabetes, that came much later, sometime between 120 and 200 CE. A Greek physician, Aratus of Cappadocia, he coined it.
It means something specific, right?
It literally means to siphon or flow through.
Ah, because of the frequent urination.
Exactly. That was one of the really noticeable signs. It really paints a picture, doesn't it? Siphoning through.
It does, like the body's losing something vital. And then the mellitus part, the honeyed bit, that was added even later.
Much later, yeah.
Oh.
In the 17th century, they figured out there was sugar in the urine. So mellitus is Latin for honeyed or sweet.
So diabetes mellitus sweet siphon tells the story.
It does. Reflects those two key observations made centuries apart. This long history just shows, how long we've recognized and been trying to understand this condition.
It's amazing. Okay, fast forward quite a bit. We start getting into some major scientific breakthroughs, like Dr. Paul Langerhans in the 1860s.
Right. So in 1869, Langerhans identified these little clusters of cells inside the pancreas. We now call them the islets of Langerhans.
Islets, like little islands.
Exactly. Now, he didn't actually know what they did, not in relation to diabetes anyway, but just finding them, identifying that anatomy was a huge first step.
Like mapping a new territory.
Kind of, yeah. Later on, of course, scientists figured out these specific cells, the islets, are the insulin factories. They make it, store it, release it.
Okay. And then there was that experiment with dogs, late 1880s. That sounds pretty crucial.
Oh, absolutely pivotal. In 1889, Minkowski and von Mering, they were doing other research, actually, and removed the pancreas from some dogs.
And what happened?
They noticed the dogs started urinating like crazy, and their urine had sugar in it. Classic diabetes symptoms. And tragically, the dogs died later.
Wow. But that was the proof.
It was the first really clear scientific link. Removing the pancreas caused diabetes, a total light bulb moment connecting that specific organ to the disease.
Must have been huge. Sad for the dogs, obviously, but huge for understanding. And that discovery paved the way for actually finding insulin itself.
Directly. So, jump to 1921, a team in Canada, researchers Banting, Best, MacLeod, call it. They managed to isolate an extract from those islets of Langerhans in animal pancreases.
And that was insulin.
They initially called it iletin, but yes, that was insulin. A monumental breakthrough. Suddenly, there was a potential treatment.
Life-changing.
Absolutely life-saving. Just 2 years later, 1923, Banting and MacLeod got the Nobel Prize. Think about it, for people with type 1 diabetes, this discovery turned a death sentence into a manageable condition.
A true game changer. Incredible.
Yeah.
But even skipping ahead to more recent times, say mid-20th century U.S., the understanding and the impact, it was still evolving, right?
Yeah. Oh, definitely. The source points out that even in the mid-1960s, the American Diabetes Association did a survey, found that most people thought diabetes was like rare, easy to manage, didn't really affect life much.
Really? In the 60s? That's surprising.
Shows how much public education was still needed. There was this big misconception.
And then, 1974, this National Commission on Diabetes gets set up. That sounds like it really brought the scale of the problem into focus.
It really did. Their findings were pretty alarming. They estimated at least 10 billion Americans had diabetes then. It was the 5th leading cause of death by disease.
Wow.
And maybe even more shocking, it was the leading cause of new blindness cases in adults aged 20 to 74.
That really highlights the severe complication.
Exactly. It underscored why more research funding, better patient care, just more awareness was absolutely critical.
And the cost, too, wasn't just the health toll.
No, the financial burden was already huge. In 1975, the estimated annual cost in the U.S. was over $5 billion.
Billion, with a B back then.
Yep. Shows the huge economic impact alongside the human cost.
And bring us almost up to date, there was another commission formed in 2018, the National Clinical Care Commission.
Right, the NCCC. Their job is to keep evaluating federal programs related to diabetes and similar conditions, recommending improvements. It just shows this is still a major public health challenge, still a huge focus.
Okay, so that historical context is really helpful. It sets the stage for understanding the different ways diabetes actually shows up. Because it's not just one thing, is it?
Not at all. We generally talk about type 1, type 2, gestational diabetes, and there are even a few less common types.
Let's start with type 1. What's the defining feature there?
Okay, type 1. It used to be called insulin-dependent or juvenile diabetes. The key thing, it's an autoimmune disease.
Autoimmune meaning the body attacks itself.
Exactly. Your immune system, which normally fights off germs, mistakenly targets and destroys the beta cells in your pancreas.
And the beta cells are the ones that make insulin.
Correct. They're the insulin factories. So if they get destroyed, the pancreas makes very little insulin or none at all.
So the body's own defenses take out the insulin production. That sounds serious. And the old name, juvenile diabetes, suggests it hits younger people mostly.
Typically, yes. It's usually diagnosed in children and young adults, but it can actually occur at any age.
And because there's no insulin, that key we talked about.
Right. The sugar can't get from the blood into the cells for energy. So blood sugar goes up, and eventually you get sugar spilling into the urine.
Which means for someone with type 1, taking insulin isn't just helpful, it's essential for survival.
Absolutely essential. They must take insulin injections, pump, whatever, just to live because their body can't make it. It accounts for maybe 5% or so of all diabetes cases.
Only 5%. Are there known risk factors? Like, why does the immune system do this in some people?
Well, the exact cause isn't fully known, but research points to a few things. Family history is one. Having a parent or sibling with type 1 increases risk, suggesting genetics play a role.
Okay.
Certain environmental factors, maybe exposure to some viruses, might act as triggers in people who are genetically susceptible. Also, the presence of specific things called diabetes autoantibodies. These are like markers showing the immune system is already gearing up for that attack on the beta cells.
Like warning signs in the blood.
Kind of, yeah. And interestingly, being Caucasian is also listed as a risk factor, seems to be more common in that population. But, and this is really important, right now there's no known way to prevent type 1 diabetes.
Right. You can't stop that autoimmune process from starting, as far as we know. Okay, let's shift to type 2 then. This is the big one, numerically speaking.
Yeah, by far. Type 2 accounts for like 90 to 95% of all diabetes cases.
Huge majority.
And unlike type 1, it's most often diagnosed in middle-aged and older folks. That's why it used to be called adult-onset diabetes, though sadly we're seeing it more and more in younger people now, too.
And the initial management approach is often different.
hmm
Less about immediate insulin.
Generally, yes. For many with type 2, the first steps involve lifestyle changes, things like healthier eating, getting more active, losing weight if needed. There are also lots of non-insulin medications, pills mostly. They can help the body use its own insulin better, or sometimes help the pancreas make a bit more.
So with type 2, the body is usually still making insulin, at least at first.
Yes, often normal amounts, sometimes even more than normal, especially early on. The problem is the body's cells aren't responding to it properly. That's called insulin resistance.
Ah, okay. We'll definitely circle back to insulin resistance. But what are the main drivers thought to be for developing type 2? Is it mostly lifestyle?
It's seen as primarily a mix of lifestyle factors. Diet, activity levels, weight, and genetic predisposition. Family history plays a role here too.
Right.
But our source also notes it can sometimes be linked to other things. Damage to the pancreas, maybe from surgery or pancreatic cancer. Certain medications can trigger it. Or even hormonal diseases like Cushing's syndrome or hyperthyroidism.
So it's complex, not just one cause.
Definitely more complex, potentially multiple factors involved.
And there's a pretty long list of things that make someone more likely to develop type 2, isn't there?
Oh yeah, quite a list. Age is a big one. Risk goes up after 45. Being overweight or obese is a major factor.
Lack of exercise.
Yep. Being physically inactive less than 3 times a week. Having a close family member, parent, sibling, child with type 2.
History of heart problems.
History of heart disease or stroke, yes. Smoking is another big one. Increases risk by like 30, 40%.
Yeah. Another reason to quit. What else? Things related to pregnancy.
Yeah, having had gestational diabetes during a pregnancy, or having polycystic ovary syndrome, PCOS, or even giving birth to a larger baby over 9 pounds.
Okay. Health markers too.
High blood pressure, having low levels of HDL, the good cholesterol, or high triglycerides, even having depression is linked.
Physical stress, like being really sick.
Yes, significant physical stress, certain meds like steroids, having other autoimmune diseases, problems with the pancreas itself.
It seems like a web of interconnected factors, and the source mentioned a physical sign too. Something about skin.
Right, a condition called acanthosis nigricans. It's where you get dark, thick, velvety patches of skin, often in body folds like the armpits or neck. It can be a sign of insulin resistance.
Good to know. And risk varies by ethnicity too.
It does. Certain groups have a higher prevalence. African Americans, Hispanic or Latino individuals, Native Americans, Alaskan Natives, Asian Americans, Native Hawaiians, and Pacific Islanders. It's important for people in these groups to be extra aware of the risks and maybe get screened earlier.
Really important point. Okay, so type 1, type 2, then there's gestational diabetes. That's the pregnancy-specific one.
Exactly. Gestational diabetes is diagnosed during pregnancy in women who didn't have diabetes beforehand.
What causes that?
It's thought to be a mix. Hormonal changes during pregnancy definitely play a big role. Some placental hormones can actually interfere with insulin's action, causing some insulin resistance.
Oh, okay.
Plus, underlying genetics and lifestyle factors probably contribute too.
Does it go away after the baby's born?
Usually, yes. Blood sugar levels typically return to normal post-delivery. But, and this is key, having had gestational diabetes increases the risk for both the mother and the child of developing type 2 diabetes later in life.
So temporary during pregnancy, but with potential long-term echoes.
Got it. And there were a couple of less common types mentioned too.
Yeah, briefly. Monogenic diabetes caused by specific single gene mutations, and cystic fibrosis-related diabetes, which can happen in people with CF due to pancreas damage. Less common, but distinct forms.
Okay, so clearly a few different phases of diabetes. Recognizing the signs is the next big step. But you mentioned earlier, with type 2 especially, people might not notice symptoms for a long time.
That's a huge challenge with type 2. The symptoms often creep up really slowly. They can be quite mild at first. People might dismiss them or just not notice them for months, even years.
Which is why screening based on risk factors is so vital.
Exactly. Type 1 symptoms, on the other hand, tend to come on much faster, sometimes over just weeks or days, much more dramatic usually. But despite the different onset speed, are there common warning signs for both types people should look out for?
Yes, definitely. There's quite a bit of overlap. Things like urinating a lot more often than usual, especially noticeable at night.
All right.
Feeling really thirsty, having a dry mouth even if you're drinking, feeling much hungrier than normal, sometimes even right after eating.
Unexplained weight loss.
Yes, losing weight without trying. That can happen even with increased hunger. Also, finding ketones in the urine that's more common in type 1, it's a byproduct when your body burns fat for fuel instead of sugar.
Other things. Feeling run down.
Yeah, feeling unusually irritable or fatigued, getting frequent infections, skin infections, UTIs, yeast infections, cuts or sores that take a long time to heal.
Vision problem.
Blurred vision, definitely. Issues with sexual function can sometimes be a sign. Dry, itchy skin. And numbness or tingling, often in the hands or feet. That's nerve-related.
That's a pretty comprehensive list. And you said type 1 might have some additional specific symptoms.
Yes, people developing type 1 might also experience nausea, vomiting, and stomach pains. Sometimes these get mistaken for the flu or a stomach bug, which can delay diagnosis.
Right. So if someone is experiencing any of those, or they know they have some of the risk factors we talked about earlier, being overweight, family history, certain ethnicities, when should they really talk to a doctor about getting tested?
Honestly, anyone experiencing those symptoms should definitely get checked out. But the source also flags specific risk factors that warrant testing even without obvious symptoms.
About what?
Having had gestational diabetes before, being told you have prediabetes, having delivered a baby over 9 pounds, being overweight or obese, being over, say, 25, especially with other risk factors, strong family history of type 2, having PCOS, belonging to one of those higher risk ethnic groups. Basically, if you tick several risk boxes, a conversation with your doctor is a really good idea. Better safe than sorry.
Makes sense. And for pregnancy, there's a standard screening time for gestational diabetes.
Yes, typically screening happens between 24 and 28 weeks of pregnancy. It usually starts with a glucose challenge test, and if that's high, a longer glucose tolerance test follows.
Okay. Now, the source also mentioned something called brittle diabetes. That's unstable.
It is. Brittle diabetes isn't really a separate type, but more a description of very difficult to control diabetes, usually type 1. People experience really wild, unpredictable swings in blood sugar. Highs, lows, often without clear reasons, even when they're following their treatment plan carefully.
Like a roller coaster.
Exactly. It makes managing daily life incredibly challenging and stressful.
And those extreme swings must have serious consequences.
They can. Frequent severe lows, hypoglycemia, or highs, hyperglycemia, increase risks. It can lead to fainting, damage to the autonomic nervous system, the part controlling involuntary things like heart rate, digestion, and various digestive problems, too. It really impacts quality of life and requires very intensive management.
Definitely underscores the potential complexity. Okay, so if someone suspects diabetes or has risk factors, what are the main tests doctors use to actually diagnose it?
There are a few key tests. A very common one is the fasting plasma glucose test, or FPG.
Fasting means no food.
Right. You fast, usually for at least 8 hours, nothing but water. Then they test the glucose level in your blood plasma. Below 99 milligrams per deciliter, mgdl, is generally considered normal.
Okay, so that's a snapshot after fasting. What about the random plasma glucose test, RPG?
The RPG test checks your blood sugar at any time, doesn't matter when you last ate. Normal is usually considered less than 199 milli-GDL if you haven't fasted. It's useful for a quick check, especially if someone has severe symptoms, but a high random result usually needs confirmation with an FPG or an A1C test.
Ah, the A1C. That seems like a really important one because it looks back over time.
Exactly. The A1C, or hemoglobin A1C, HbA1c, it measures your average blood sugar over the previous 2 to 3 months. No fasting needed for this one.
How does it do that? How does it measure an average?
Okay, so glucose in your blood sticks to hemoglobin, the protein in your red blood cells that carries oxygen. The higher your blood sugar has been, the more glucose gets stuck to the hemoglobin.
Right.
And red blood cells live for about 3 months. So the A1C test measures the percentage of your hemoglobin that has glucose attached. It gives a great picture of your overall control during that period. Below 5.7% is normal.
So it's like an average grade for your blood sugar over the last quarter.
That's a great way to put it. For people diagnosed with diabetes, doctors usually recommend getting an A1C test at least twice a year, sometimes more often, to see how well the management plan is working.
And the source mentioned something about A1C results potentially varying in different ethnic groups.
Yes, that's an important point. Some types of hemoglobin variants, more common in people of African, Southeast Asian, or Mediterranean descent, can sometimes affect the accuracy of the standard A1C test. Doctors need to be aware of this and might consider other tester factors too.
Good to know. And the last main test was the glucose tolerance test, mostly for gestational diabetes. Sounds more involved.
It is a bit. For gestational diabetes, usually you fast overnight. Then you drink a specific sugary liquid, usually containing 75 grams of glucose.
Okay.
Then they check your blood sugar levels at timed intervals, typically after 1 hour, 2 hours, maybe even 3 hours. A specific high reading at the 2 hour mark, usually 140 milledel or more, indicates gestational diabetes. It tests how well your body handles that sugar load during pregnancy.
Okay, so several different tools giving different pieces of the puzzle. The source had a table too, right, showing the ranges for normal, pre-diabetes, and diabetes for those main tests.
Yes, a really useful table. It clearly lays out the cutoff points for FTG, A1C, and sometimes RPG that define those categories based on ADA guidelines. Shows that road to type 2.
Definitely helpful.
Mm.
So once someone is diagnosed, the day-to-day management becomes the focus. And a huge part of that is checking blood sugar levels at home.
Absolutely fundamental. Regular self-monitoring of blood glucose, or SMBG, is essential. It helps you see how food, activity, medication are affecting your levels. It helps prevent dangerous lows or hypoglycemia, and it gives you and your doctor the data needed to make adjustments to your treatment plan.
Are there target ranges people should aim for?
Yes, though individual goals can vary, but general targets for many adults with diabetes are before a meal, aiming for 80 to 130 milligdl, and then 2 hours after the start of a meal, aiming for less than 180 milligdl. But again, you really need to discuss your personal targets with your doctor.
And how often do people need to check? Does it vary a lot?
It varies hugely. Depends on the type of diabetes, the treatment. Are you on insulin, multiple injections, a pump? Oral meds only, how stable are your levels? Someone on intensive insulin therapy might check 4, 6, even more times a day. Someone managing type 2 with diet might check less often.
What are common times to check?
Typical times include first thing in the morning, fasting before meals, 1 or 2 hours after meals, and at bedtime. It's also really important to check more often if you're sick, if you change your routine, or if you feel like your sugar might be low or high.
And the actual process, the finger prick, the meter, can you just quickly walk through that?
Sure. First step, always wash and dry your hands well. Then you use a lancing device, that little spring-loaded pen thing with a fresh lancet, a tiny needle, to prick the side of your fingertip.
Size better than the pad.
Usually less sensitive, yeah. Gently squeeze out a small drop of blood. You apply that drop to the test strip, which you've inserted into your glucose meter. Wait a few seconds, and the meter displays your reading. Always follow the instructions for your specific meter, though.
And keeping a log of those readings is important too, right?
Oh, definitely. Writing down your numbers, maybe the time, what you ate, activity, meds, either in a logbook or an app. It helps you and your doctor see patterns, understand triggers, and make adjustments. Bring that log to your appointments.
Now, beyond finger sticks, there's continuous glucose monitoring, CGM. That sounds more high-tech.
It is. CGM uses a tiny sensor inserted just under your skin, usually on the belly or arm. This sensor measures glucose in the fluid between your cells, the interstitial fluid, continuously.
Continuously, like 204/7.
Pretty much. It sends readings wirelessly, usually every few minutes, to a receiver or your smartphone. The big advantage is you see not just the number, but also trends. Is your glucose rising, falling, how fast?
So you get a moving picture instead of just snapshots. What are the benefits?
You get a much better understanding of how things affect your glucose throughout the day and night. It can alert you if you're going too high or, crucially, too low. This is huge for preventing severe hypos, especially for people who don't always feel the warning signs.
That sounds incredibly helpful for managing insulin doses too.
Definitely. The data is really valuable for fine-tuning insulin. The source does advise, though, that it's often still recommended to confirm a CGM reading with a finger stick before making a major treatment decision, like taking extra insulin, especially if the reading doesn't match how you feel.
Good safety check.
Yeah.
Okay, shifting focus a bit, understanding your risk of developing diabetes in the first place. The source had a risk assessment questionnaire. What kind of things does that look at?
Those tools typically assess key risk factors for type 2. Age is usually in their risk increases as you get older. Family history, parents, siblings with diabetes, that's important.
For women, gestational diabetes history.
Yes, definitely. Lifestyle factors are key. How active are you? What's your weight status? Questions about high blood pressure or high cholesterol are common too, as they often go hand in hand with diabetes risk.
Ethnicity might be included too.
Sometimes, yes, because of those known variations in risk across different populations. Answering these helps you gauge your personal risk level and decide if you need that conversation with your doctor about screening.
And body mass index, BMI, is another tool mentioned for weight-related risk.
Right. BMI is a common screening tool, though it has limitations. It's basically a ratio of your weight to your height. The standard formula is weight in kilograms divided by height in meters squared, or if you use pounds and inches, it's weight in pounds divided by height in inches squared, then multiply by 703.
And a higher BMI generally means higher risk.
Falling into the overweight or obese categories based on standard BMI charts is associated with increased risk for type 2 diabetes. But remember, it doesn't account for muscle mass, so it's just one piece of the picture.
Which leads to those at-risk weight charts in the source. They were interesting because they were specific to ethnicity and height. How do those work?
Yeah, those are quite specific. They give actual weight ranges for different heights, categorizing them as above normal, high, or very high risk for type 2 diabetes.
Yeah.
Crucially, there are different charts depending on whether you identify as Asian American, Pacific Islander, or neither.
Why the different charts?
Because research shows that healthy weight ranges and the point at which diabetes risk increases can differ between ethnic groups. For example, people of Asian descent might develop diabetes risk at a lower BMI or weight than people of European descent. So you find your height, look across to find your weight, and see which risk category it falls into on the chart relevant to your ethnicity. It's a more tailored look at weight-related risk.
That personalized approach seems really important. Now, we've mentioned prediabetes a few times. The source called it a critical window. Why is that so significant?
Prediabetes means your blood sugar levels are higher than normal, but not quite high enough yet to be diagnosed as type 2 diabetes. It's sometimes called borderline diabetes or impaired glucose tolerance. It's a critical window because this is the stage where you often can prevent or significantly delay progressing to full-blown type 2 diabetes through lifestyle changes.
But many people don't know they have it.
That's the scary part. About 1 in 3 U.S. adults has prediabetes, and most are completely unaware. They often have no symptoms.
Wow. But it is reversible or manageable.
Yes. Studies clearly show that making changes, healthier eating, more physical activity, losing even a modest amount of weight can drastically cut the risk of developing type 2.
Any subtle signs someone might notice with prediabetes?
Sometimes. While often symptom-free, some people might develop that darkened skin, acanthosis nigricans, in the armpits or neck, or maybe skin tags in those areas. These can be hints of underlying insulin resistance.
So early detection via blood tests like FPG or A1C is key if you have risk factors. And if diagnosed with prediabetes, what kind of weight loss makes a difference?
The source suggests that if you're overweight, losing even 5 to 7% of your body weight can make a huge difference. That's often a realistic and achievable goal. For a 200-pound person, that's just 10 to 14 pounds.
That sounds doable for many.
It really can be. And it's mainly achieved through healthier eating, cutting back on sugary drinks, processed foods, unhealthy fats, and increasing physical activity. Working with a doctor or dietitian on a plan is always best.
Absolutely. Now let's properly define insulin resistance. We've said it's key in type 2 and prediabetes. What's actually happening?
Okay, insulin resistance means your body cells, mainly in your muscles, liver, and fat tissue, aren't responding properly to insulin's signal. Insulin is there, knocking on the door, but the cells aren't opening up easily to let the glucose in.
So the key isn't working well in the lock.
Good analogy. As a result, glucose starts to build up in the blood. To compensate, the pancreas works overtime, pumping out more insulin to try and force the glucose into the cells.
It's shouting louder, basically.
Exactly. For a while, the pancreas might keep up, but eventually it can get worn out or just can't produce enough insulin to overcome the resistance, and that's when blood sugar levels consistently rise into the prediabetes or type 2 diabetes range.
And the source said insulin resistance always happens in late pregnancy. Is that why gestational diabetes occurs?
Yes, that's a major factor. Hormones from the placenta naturally increase insulin resistance in the later stages of pregnancy. This is partly to make sure the baby gets enough glucose. But in some women, their pancreas can't produce enough extra insulin to counteract this resistance, leading to gestational diabetes.
Does insulin resistance itself cause symptoms?
Usually not directly, no. The symptoms come later when blood sugar starts to rise. The main drivers are thought to be excess weight, especially around the belly, inactivity, genetics, family history.
Okay, so again, healthy weight and activity are protective. Let's talk medications now. They play a huge role once diabetes is diagnosed.
A vital role for many people. The main categories are insulin and various oral diabetes medications, often pills. Sometimes other injectable medications are used too. Often people might need a combination.
And the choice depends on the type of diabetes and how well controlled someone is.
Exactly. And other health factors, cost, side effects. It's very individualized.
We know type 1 absolutely requires insulin. What about type 2?
With type 2, it's often a progression. Many people start with lifestyle changes, then add oral medications. But because type 2 can be progressive, meaning the pancreas's ability to make insulin can decline over time, many people with type 2 eventually do need to add insulin to their regimen to maintain good control.
And gestational diabetes, meds used there.
Lifestyle changes, diet and exercise are always the first step. If that's not enough to keep blood sugar in target, then medication is needed. Insulin is very common because it's safe for the baby, doesn't cross the placenta. Sometimes the oral medication metformin might be used, though that's usually discussed carefully with the doctor.
And a reminder, always tell your doctor about everything you take, even supplements or over-the-counter stuff, right?
Yeah.
And ask about things like aspirin if needed.
Crucial. Interactions can happen.
Okay, let's dive deeper into insulin. Lots of ways to get it into the body.
The most common are the traditional needle and syringe, insulin pens, and insulin pumps. Less common methods include injection ports, inhaled insulin, and jet injectors.
Key safety point. Never switch your insulin type or brand without talking to your doctor.
Absolutely critical. They're not interchangeable. Also, be aware of potential side effects like low blood sugar, hypoglycemia, maybe some weight gain, or skin reactions at the injection site.
And storage is super important too, isn't it? Can't just leave it lying around.
Definitely not. Unopened insulin needs refrigeration. Protect it from light and extreme heat or cold, never freeze it. Once opened, a vial or pen can usually be kept at room temperature for about a month. But check the specific instructions for your type. Always check the expiration date. Don't shake it violently. And use an insulated bag when traveling.
Got it. Now, there isn't just one insulin. There are different types that work differently.
Correct. They vary in how fast they start working onset, when they have their strongest effect, peak, and how long they last duration.
Can you give us the main categories?
Sure. There's rapid acting, starts working in about 15 minutes, peaks in an hour or two, lasts maybe 2-4 hours, often taken right before meals. Regular or short acting, starts in about 30 minutes, peaks in 2-3 hours, lasts 3-6 hours. Intermediate acting, like NPH, slower onset, 2-4 hours, peaks around 4-12 hours, lasts maybe 12-18 hours. Long acting, very slow onset, minimal or no peak, provides a steady background level for about 24 hours. Ultra long acting, even longer duration, maybe 36 hours or more, also very flat action. And then there's inhaled insulin, rapid acting, inhaled through the lungs.
And they have different concentrations too.
U100, 100 units per milliliter is the standard in the US, but more concentrated forms like U200 or U500 exist for people needing larger doses. Using the right syringe or pen device for the concentration is vital.
So tailoring the type and timing of insulin is really precise work with your doctor. Let's look at the delivery methods. Needle and syringe the classic way.
Still widely used, you draw the dose from a vial into a syringe and inject under the skin. Matching the syringe to the insulin concentration, usually U100, is key. And rotating injection sites, belly, thighs, buttocks, upper arms is super important.
To rotate.
To prevent lipohypertrophy, lumps of fatty tissue that can build up under the skin and mess with insulin absorption. Insulin absorbs fastest from the belly, by the way. Keeping a log of sites helps.
Insulin pens seem more convenient, maybe?
For many people, yes. They look like pens, hold an insulin cartridge, and you dial up the dose. Easier to carry, more discreet, potentially simpler to use than vials and syringes, especially if dexterity is an issue. Some are disposable, some use replaceable cartridges. Might cost a bit more upfront.
And insulin pumps the techie option. Continuous delivery.
Right. A small computerized device worn externally. It delivers insulin 24/7 through a thin tube, cannula, inserted under the skin. You program a background basal rate and then give bolus doses for meals or high sugar corrections.
Different kinds of pumps.
Yep. Traditional ones have tubing connecting the pump worn on a belt pocket to the infusion site. Tubeless patch pumps stick directly to the skin. Pumps offer flexibility, potentially tighter control, fewer injections, but require significant training and monitoring.
Injection ports, what are those?
A small, soft tube inserted under the skin with an adhesive patch. You inject your insulin through the port using your pen or syringe instead of directly into your skin each time. Reduces needle pokes, needs changing every few days.
Inhaled insulin, that sounds different.
It is a rapid-acting insulin powder you inhale, absorbed through the lungs. Approved for adults with type 1 or type 2, not for everyone, especially those with lung issues, and type 1 users still need long-acting injectable insulin too.
And finally, jet injectors. No needles.
Right, they use high pressure to force a fine stream of insulin through the skin. Less common, can sometimes cause bruising or discomfort.
Okay, lots of options for insulin delivery. Now, what about the oral medications for type 2? The pills.
Metformin is the most common starting point usually. Comes as pills or liquid, but it's crucial to remember these pills are not insulin. They work in different ways.
How do they work then?
Some, like sulfonylureas, stimulate the pancreas to release more insulin. Metformin primarily reduces glucose production by the liver and improves insulin sensitivity in muscle cells. Idesolidaneones, TZDs, also improve insulin sensitivity. Others, like SGLT2 inhibitors, make the kidneys flush out more glucose in urine. DPP4 inhibitors help increase insulin release after meals and decrease liver glucose output. Alpha-glucosidase inhibitors slow down carb absorption in the gut.
So different mechanisms targeting different aspects of the problem. Any other benefits, like weight?
Metformin is often associated with stable weight or even modest weight loss for some. Some newer classes, like SGLT2 inhibitors and GLP-1 receptor agonists, which are usually injectable, not oral pills, can also promote weight loss.
And if one pill isn't enough?
Combination therapy is very common, using 2 or more oral meds with different actions, or adding an oral med to insulin, or using other injectable non-insulin drugs. It's all about finding the right mix for that individual.
The source also mentioned a few less common, maybe more specialized treatments.
Yeah, briefly. The artificial pancreas or closed-loop system, that's the CGM, linked to an insulin pump that automatically adjusts insulin delivery, getting smarter all the time.
Right.
Pancreatic islet transplantation, transplanting healthy insulin-producing cells from a donor, usually reserved for type 1 folks with severe control problems or hypoglycemia unawareness. It's complex, requires
Some
immunosuppression.
bariatric surgery, weight loss surgery.
Yes, for some people with significant obesity and type 2 diabetes, weight loss surgery can be incredibly effective, often leading to major improvements in blood sugar, sometimes even remission of diabetes, at least for a time.
So while there's no magic cure yet, it sounds like there's a huge toolkit for managing diabetes effectively.
Absolutely. And the source really stresses that you, the person with diabetes, are the most important part of the management team. What you do every single day matters most.
Building a support network is key too.
Crucial. Family, friends, caregivers, and your healthcare team. Primary doctor, maybe an endocrinologist, dietitian, diabetes educator, eye doctor, foot doctor, pharmacist. Don't be afraid to ask questions at appointments.
And those core lifestyle things we keep coming back to.
Healthy eating, physical activity, managing blood pressure and cholesterol, definitely quitting smoking if you smoke. These are the foundations. Joining support groups can also be really helpful, connecting with others facing similar challenges.
And the source broke down care into daily, quarterly, and annual tasks. That seems like a good framework.
Yeah, really practical. Daily. Check blood sugar as advised, check your feet for any issues, take your meds, eat healthy, trying to get that 30 minutes of activity.
Feet are important.
Very. Nerve damage and circulation problems can mean you don't feel injuries, which can lead to serious infections. Daily checks are vital.
Good.
Quarterly. Doctor visit every 3 months, maybe every 6, if you're meeting your goals consistently and feeling good. A1C check usually happens then too.
And annually.
Big checkup time, flea shot, kidney function tests, urine and blood, cholesterol check, dilated eye exam to screen for retinopathy, thorough foot exam by a professional.
Any specific vaccines mentioned?
Yeah, besides the annual flu shot, Hep B vaccine series recommended for adults up to age 60, and pneumonia vaccine, often starting before 65, maybe boosters later. Talk to your doctor about what's right for you.
And when should you definitely call the doctor outside of scheduled visits?
If you have new or worsening symptoms, if you're feeling persistently down or depressed, if you're having trouble taking your medications for any reason, don't wait.
Okay, now nutrition. Huge topic. The source wisely says, talk to your doctor before any big diet changes, especially super low-carb ones.
Absolutely essential advice. And ideally, consult a registered dietitian, preferably one who's a certified diabetes care and education specialist, CDCES. Check if your insurance covers it. Many do. They can create a personalized plan.
Understand carbs is key, right?
Yeah.
Carb counting.
Yes, because carbs have the biggest impact on blood sugar. Learning how to estimate or count carbs in your food helps you manage portions, and if you take mealtime insulin, match your dose to your intake. Consistency is also important. Eating regular meals, not skipping. Tracking what you eat, planning meals ahead. These things really help.
The source had some really practical tips for healthy eating day to day.
Yeah, great stuff. Shop with a list, find recipes online. The ADA website is a good resource. Make cooking fun, involve the family. Look for healthier swaps for ingredients. Choose fresh, whole foods over processed stuff whenever possible.
Portion sizes. Always tricky.
Watch those portions. Enjoy favorite foods, but in moderation. Use healthy oils instead of solid fats. Pack lunches and snacks. Flavor with herbs and spices instead of salt. Cook extra and freeze for busy days.
What are the main goals of this kind of medical nutrition therapy?
Keep blood glucose as close to normal as possible. Get adequate nutrition. Manage weight. Achieve healthy blood fat levels, cholesterol, triglycerides. And ultimately prevent or delay those long-term complications.
And the more versus fewer food lists. Good general guide.
Yeah, helpful framework. More of. Non-starchy veggies, broccoli, spinach, peppers. Lean proteins, chicken, fish, beans, tofu. Fruits in moderation, whole grains, brown rice, quinoa. Healthy fats, nuts, seeds, olive oil, water.
And fewer of?
Processed foods, starchy foods in large amounts, white bread, potatoes, trans fats, high sodium foods, sweets, sugary drinks, excess alcohol.
In those hand-based portion guides, palm for protein, fist for veggies.
Yeah, visual guides can be super helpful when you're starting out. Palm of hand, no fingers, is about 3 ounces of meat fish. Fist is about a cup. Thumb is about an ounce of cheese or 2 TBSP peanut butter. Cupped hand for cooked grains pasta. Fingertip for a teaspoon of fat. Rough guides, but useful.
And the perfect plate model. That sounds simple.
Very visual. Imagine your plate. Fill half with non-starchy vegetables. Fill 1/4 with lean protein. Fill the last quarter with whole grains or healthy starches. Great starting point for balanced meals.
Okay, moving to exercise, another cornerstone. The benefits listed were really extensive.
Huge benefits. Burns calories, helps weight control. Directly lowers blood sugar, improves insulin sensitivity. Boosts mood, confidence. Helps heart health, lowers blood pressure. Improves circulation, memory. Better sleep. Prevents falls. Just generally makes you feel better.
But again, check with the doctor first, especially before starting something new or intense.
Always. And don't exercise if you have ketones in your urine that needs medical attention first. The key is finding activities you enjoy. Walking, gardening, dancing, swimming, biking, team sports, whatever gets you moving.
How much should people aim for?
The general recommendation is at least 150 minutes of moderate intensity aerobic activity per week. Spread it out. Even short bursts count.
What's moderate in intensity?
You can talk but not sing easily, like brisk walking. Vigorous intensity is where you can only say a few words without pausing for breath.
Any tips for sticking with it?
Schedule it like an appointment. Start slow. Keep walking shoes visible. Drink water. Sit less overall. Find a buddy. Use trackers or apps if they motivate you. And don't forget strength training.
Why strength training?
Builds muscle, and muscle uses glucose more efficiently, improving insulin sensitivity. Aim for exercises working all major muscle groups at least twice a week: weights, resistance bands, body weight exercises.
And planning ahead for exercise is important too, especially regarding blood sugar.
Crucial, particularly if you take insulin or certain meds. You might need to adjust insulin doses or eat a snack before, during, or after to prevent low blood sugar, hypoglycemia.
So checking blood sugar around exercise is key.
Yes, check before, during if it's long, and after, especially when you're new to an activity. Eat a carb snack before if needed. Have fast-acting carbs handy just in case of a low. Stay hydrated.
And watch out for delayed lows.
Yeah, sometimes blood sugar can drop hours after strenuous exercise. Having a snack with carbs, protein, and fat after a long workout can help prevent that.
Okay. Stress management that affects blood sugar too.
Big time. Stress hormones can raise blood sugar and make insulin less effective. Finding healthy ways to cope is part of diabetes management.
What helps?
Regular exercise is a great stress reliever. Getting enough sleep, 7-8 hours. Relaxation techniques like deep breathing, yoga, meditation. Talking to your doctor or a therapist if stress feels overwhelming.
And then sick days. They can really throw things off, can't they?
Illness or injury can definitely raise blood sugar and make insulin work less well. Managing sick days properly is vital.
What's the #1 rule?
Never skip your diabetes meds, especially insulin. Even if you can't eat much, you might even need more insulin. Call your doctor for guidance on doses if you're unsure.
Keep trying to follow the meal plan.
As best you can. Drink plenty of fluids, mostly calorie-free, like water. If you can't eat solids, try small sips of sugary liquids if your sugar is low or you need carbs, but check with your doctor. Broth, sugar-free gelatin are good options too.
Check blood sugar more often when sick.
Definitely. It can be high even if you're not eating much. For type 1, check urine for ketones if blood sugar stays over 240 mg/dl on 2 checks. High ketones can mean DKA, diabetic ketoacidosis, which is a medical emergency.
When should you absolutely call the doctor on a sick day? Red flags.
Blood sugar consistently over 240 despite following sick day rules. Fever over 101 degrees Fahrenheit. Trouble breathing. Vomiting or diarrhea for more than 6 hours. Losing weight rapidly, like 5 pounds. Feeling very tired or confused. Signs of dehydration. Persistent fever. Moderate or large ketones in urine or fruity breath. Don't hesitate to call.
Okay, so we know some risk factors can't be changed, but lifestyle choices can really help prevent type 2.
Absolutely. Healthy eating, regular activity, maintaining a healthy weight, not smoking, limiting alcohol, managing stress. These are the big preventative steps for those at risk. And again, know the symptoms and get tested early if they appear. Early treatment drastically reduces complication risks.
And looking ahead, the research sounds really promising. What were some highlights?
For type 1, researchers are working on ways to stop that initial immune attack, focusing on things like those hybrid insulin peptides, HIPs, to potentially re-educate the immune system.
Needle-free monitoring. That sounds appealing.
Huge area of research. Using electromagnetic waves, lasers, radio waves. Also, implantable CGMs, maybe even under the eyelid eventually, making monitoring less painful and intrusive.
Immunotherapy, too.
Yes, trying to target just the specific immune cells attacking the pancreas. Or developing vaccines to reduce the inflammation involved in autoimmune diseases. Lots of hope for better prevention and treatment down the line.
Very cool. Circling back one last time to carbs, seems like managing them is always central.
It really is. The amount, the timing, the type of carb, it all matters for blood sugar. The right amount is totally individual, needs that discussion with your healthcare team. And learning to count carbs, especially for insulin users, is a key skill. Also, knowing how to treat lows without overtreating and causing a high later.
And eating out. Possible with planning.
Totally possible. Check menus ahead. Avoid buffets maybe. Swap fries for veggies. Choose grilled baked over fried. Get sauces on the side. Be mindful of extras. Ask for modifications. It just takes a bit more awareness.
Finally, those resources, AD, ADCES, and IDDK, great places for more info.
Excellent, reliable sources. Websites have tons of information, recipes, support links, research updates. Highly recommend checking them out.
Well, this has been an incredibly thorough deep dive. We've covered so much ground: the history, the types, diagnosis, management, prevention, research, drawing from that great quick study guide.
It really is a multifaceted condition, isn't it? From ancient descriptions to today's high-tech management, what really stands out is how much proactive self-care and lifestyle choices empower people living with diabetes.
Absolutely. It takes effort, no doubt, daily effort. But understanding the condition, using the tools and resources available, it makes living a healthy life totally achievable.
And the ongoing research offers so much hope for the future, too.
It really does. So a final thought maybe for you listening, considering everything we've talked about, what's one thing about diabetes, maybe a management tip, a risk factor, a piece of research that really resonated with you or felt particularly empowering?
Yeah, maybe take a moment on that. Perhaps explore one of those resources we mentioned to learn a bit more about that specific area. Because staying informed and engaged is such a powerful part of the journey.